Hi, I've been coughing all week, so I've got kind of like a 1-900 quality improvement voice going on, so bear with me. So my project looked at trying to increase organ donor rates through interventions in family medicine offices. We know that a ton of Canadians support organ donation, but not a lot of those people have actually made any sort of effort to become a donor. And there's not any good Saskatchewan data around how many donors we have or why. So why in the family medicine office? We see people anyway. They're in our offices. We see them for regular visits, and we've seen them for long enough that they trust us. So it's often less uncomfortable to have a discussion about end-of-life matters with somebody that you already know in a setting that's not urgent. So it's easier to talk about it while you're well with somebody that you know and hopefully like than if it's in a crisis situation. So we tried to increase the organ donor rates within our clinic by 50% and to also improve how this was documented within our EMR. We collected some baseline data, and so I was actually surprised that when we looked at our patients, more than half of them said that they were organ donors. Interestingly, of those people, only a fraction had told anybody that they were an organ donor or had it documented in any way. If they weren't an organ donor, we looked at why, and about a third of the people said that they just never thought about it, which I thought was our opportunity. So we tried to target the periodic health exam. That's what the complete checkup is. We had our MOAs hand out some information and a donor card to patients when they put them in the room, hoping that that would cue the physician, that they would see the patient holding a thing, and they would have that discussion. And then we asked physicians to code that status. How did it go? We went from 0 patients with a coded donor status, because we didn't have that as an item, to 52 in a 2-month period. And at first I was like, yeah, awesome, 52 people. But we did 238 complete checkups in that time, so wasn't great. And we didn't relook at our baseline data just because there wasn't enough time. Our MOAs often forgot to hand out their information packages. We actually ran out of cards and nobody told me, so that set up a delay for us. And our physicians often just forgot or felt like they were trying to talk about too many things during that visit already. What went right? We were really trying to not make it be a time-intensive thing. So the MOA said it took less than 1 minute of their time. The physicians thought it took maybe 2 minutes of their time, and our RN actually picked up on it and suggested that it would be a good thing for her to talk about when she did pre-screening phone calls. So we're going to try another cycle. We're going to get our RN to standardize doing it in her pre-screening phone calls. We're going to make sure we have enough handouts, and we're going to move it to a different visit type. So what I learned from CQIP, research is scary, but quality improvement is maybe a little bit less scary. And you can do it in family medicine, which is often what people worry about, is that research can't be done in a family practice setting. And there's my acknowledgement.